Good evening, friends. Welcome to the second. Good evening, friends. Welcome to this second webinar on the movement disorders and neuromodulation in movement disorders. Uh, First of all, I would like to thank Electra Division, Intas Pharmaceutical, for their wholehearted and continued support in help in organizing this webinar and also supporting this educational activity. And today I'm joined in this webinar presently by Dr. Sandeep Vaishya, who is going to be the first speaker of our webinar. Dr. Sandeep Vaishya is a head of the department and consultant neurosurgeon at Fortis Hospital, Gurgaon. He doesn't need much introduction. He has been the past president of ISSFN. And he's going to be the moderator of this session during the rest of the time. We are also joined by Dr. Ravi Verma, and he had been the moderator for the first session. And we have Dr. Milind Sankhe, who is the secretary of the ISSFN. So without spending more time, let us have the first talk going on. And I'll stop sharing my screen and Dr. Vaishya can start his screen share.
So, hello everybody. In the last webinar, we saw pathophysiology and anatomy of the basal ganglia, and we saw the various type of presentation, differentiation between various tremors, and the indication and contraindications for surgery. Now, today I'm going to talk about the surgical technique of DBS. It is a very basic talk, and it will just include the surgical flow, how we go about it. And so basically, this is meant for young neurosurgeons who have done either few cases or who have not seen a case. So as we discussed last time, the preoperative assessment of the patient by the neurosurgeon is very important. Neurologist has decided about the case that he is good for DBS, but surgeon should also see the patient to check his physical fitness, comorbidities, hypertension, diabetes, check carefully for any type of blood thinners. I have had one incident before when the patient did not tell us. And particularly look for skin and scalp infections. Patients, when you see they are with their hair, you shave the hair only during the OR. You don't want to see any infection there at that time. If there is any language barrier, then arrange for an interpreter in the OR, and then preoperative counseling of the patient and the family so that they don't have any unusual expectations from the surgery. So the workflow of surgery goes in this way. The MRI is done a day before surgery. Then frame fixation is done on the day of surgery. It can be done under general anesthesia or local anesthesia, depending on the situation. CT scan is done with the frame, and then the transfer of the MRI and stereotactic CT to the software. Then the target planning is done in the software. After that, the patient is moved in the OR, burr hole and insertion of microdrive if you're planning to do microelectrode recording, and then intraoperative assessment by the neurologist. Placement of the electrode. Till now, this is mostly done under local anesthesia, unless the surgery is being done under GA. And then the last part is the placement of the battery, which is usually done under general anesthesia. During surgery, patient should be in the most comfortable position because it is going to be a long day for him, particularly if the patient is conscious. Many patients are old patients are unable to pass urine in a lying down position, so we catheterize those patients. Careful draping should be done so that the patient should not feel claustrophobic, and yet the parts are exposed for your examination. So the infrastructure and the equipment that you require is a good quality CT, MRI, a stereotactic frame, a microdrive, microelectrode recording system, and a planning station. And the components that we implant are the electrode, the extension cable, and the battery, or the implantable pulse generator. So I will skip this target because this is going to be the topic of the next talk. Now we come to the important part of fixation of the frame. As I said, it can be done under GA or local anesthesia. If the patient is awake, then usually the frame fixation is more easy. Patient is sitting and then you can fix the frame. It is very important to fix the frame in an orthogonal position. You should strive for a perfectly symmetrically placed frame despite softwares being available. If the frame is fixed perfectly in AC plane without any pitch, yaw, or roll, in that case, the target planning, and particularly if you plan to change the target during surgery, it becomes very easy. If you see the example here, so this frame is perfectly placed. If you just change the X, it will not change anything else here. But if the frame is not perfectly placed, when you change the laterality, it will not only change the X, it will change the Y, or maybe Z also if the frame has got some roll. So commonly used frames are Lexel and CRW frames. CRW is going out, so it will be mainly Lexel now. I'll just show you a small video of how the frame is assembled. This is the footplate of the frame. Uh, this the base, and these are the footplates which go down. This is the nose plate. You can keep it in either direction. In particular, in patients with big nose, you have to sometimes put it in inferior direction. But if you keep, I prefer to keep it upward so that the mouth is open if patient requires intubation. So the nose plate is fixed. I'll just forward it a bit. And then there are 4 pillars and 2 anterior pillars which are longer and the 2 posterior pillars which are shorter. So these pillars are fixed to the frame. As you can see here, they are attached and then screwed in. And the 2 shorter posterior pillars are attached. So if you want to place the frame perfectly in orthogonal position, try to keep the pillar height also at the same level so that there will not be any roll of the frame. Both the anterior pillars and both the posterior pillars should be exactly at the same height. Now this is the earplug adapter which goes onto the Y slider. You use it to put the earplugs when the frame is ready to be put in so that there is no pitch of the frame. The frame cannot rotate or it will not roll. Now this is ready to be attached to the patient's head. So I'll just show you on a mock patient. This is our ENT surgeon. He was the only bald guy in our OT, so I used him as a model. To prevent the rotation of the frame, which cannot be avoided by the earplugs, what I do is I draw an orbitometer line, and then I make a percent stand next to the patient to keep on checking whether the frame is parallel to this line or not. So you place the frame on the patient's head, just check the location and check it whether it is parallel to this line or not. Once you are ready, then you now you see once you are ready, then you put the earplugs in. One thing you must check that some patients have got a protuberant occipital bone. If it protrudes too much, then you will not be able to put the CT adapter. So you have to be careful that the whole skull is inside the frame and no part is coming out. So now we are ready to fix the frame. You slide the anterior pillars according to your desired position. I usually keep it lower down, though it comes on the forehead because the incision in many patients comes quite anteriorly. So I don't want the pillars coming in my way. Once that is done, once everything is ready, then only you should put the earplugs in because that is the most painful part of the whole surgery. But that lasts only for a minute or so. We have already injected local anesthesia, and as soon as the effect of local anesthesia is there, you just put the screws in. So what I do is I try to choose exactly the same length of the screws also, both for the front and for the back. If the length of the screws is exactly the same and the same amount of screw is coming out after fixing it in, then you know that the frame is perfectly placed. If after checking, if I find that one of the screws feels shorter or longer, then I know that the frame position has moved and then I recheck my position. So this is frame placement on an actual patient. The frame is placed and the screws are being tightened. You tighten them in a diametrically opposite direction, and it should be 3-finger tighten. You should not tighten it too much also. And once you have tightened, you should just shake the frame a little bit to see that it is not loose. And once this is done, then the patient is ready to be taken for the CT scan. So you put a CT adapter and do a CT scan. And once the CT scan is done, that data is transferred to the planning software. So in the planning software, you merge the CT and the MRI images and then plan your target, whatever target it is. Dr. Ravi will discuss later on. And then you plan the target and the trajectory. So we have already done a double contrast MRI to look for any vessels which may come into the way. So you check for the lateral angle, the front angle, and the target. You should avoid taking a trajectory which may pass through the ventricles, because in that case there can be CSF leak and their position may change. Similarly, you should avoid going through a sulcus, because the sulcus will be carrying blood vessels and then you can injure a blood vessel. So this circle is a 5 millimeter circle depicting the area of 5 microelectrodes. So this is a safety circle. If this is not passing through the ventricles or this sulci, then you are safe. So now we are ready to assemble. We are ready to assemble this stereotactic arc and then attach it to the frame. So for this, I'll show you a small video by Electra. So this is because this is Electra's frame. So now this is how the final assembly would look. So this is the Y adapter and this is the Z ring. So the Z ring goes onto the Y adapter and then you set the Z coordinate. You do it in the same way on both the sides. And it is very important that two persons should check it, because you can very easily make a mistake in counting the numbers. So there should be double check of all the numbers. Then this goes onto the Y slider goes onto this base plate, and then you set the Y coordinate. Once the Y coordinate is set on both sides, then on the arc, you set the X coordinate on both sides. I've seen people making a mistake that while setting X coordinate, they take this Y. But you have to carefully see that you are setting the number on the X only. You do it on both sides, and now your frame is set. Now you get the arc angle by attaching this slider, because this angle was already determined by the software. So exactly at the same angle, you put the slider, and then connect the instrument guide and the stop holder. Now, once that is fit, you are ready to attach the arc to the frame. So this way you attach it. You first push it on one side, lock it in, and then you take the other side and slide it into the position. And then you tighten it. Once that is done, you set the arc angle on this, which was already predetermined. So then you set the arc angle, and now you're ready to go. So after setting all these things, wherever this thing is pointing, that is the site of your burr hole, and that will be your entry point. Now we'll start with the surgical part. So basically, we have already determined the trajectory and the site of the burr hole. So you create a burr hole. Previously, what I would see that, because we are taught to make the burr hole exactly perpendicular to the bone, but that may not be the trajectory of the electrode. So sometimes the electrode or the microelectrodes would collide with the bone. So we had to change the angle, what we had already determined. So then after that, I started doing this way. I put this guide and make the burr hole through that guide, because this guide is showing you the exact direction that the electrode will take.
क्या optics है sir? Literally, it's very
So
good.
you just loosen it so that this rotates freely, and then I make the burr hole through that. This way, I never had to change the angle after making the burr hole. Once the burr hole is done, you connect. If you are doing a microelectrode recording, then you connect the microelectrode drive, and you put in the microelectrode, depending on how many microelectrode recordings you need or you want to do. Sometimes a vein or a sulcus may be coming in the way of one of the microelectrodes, so you may not choose that. So once this is assembled, this is connected to the connectors, and which are ultimately connected to the microelectrode recording equipment. Then you put in all, here we are connecting all the microelectrodes. So this is how the final assembly looks, and then you are ready to record. But before we do this, there is one important step that we did not used to do that in the initial years of surgery. like putting in glue in this burr hole. This is very important because in initial years, we used to see a lot of patients would develop pneumocephalus, and sometimes there will be brain shift because of that, because of the CSF leakage. But once we start using this glue, that I have not seen a single case of pneumocephalus. Then you check the impedance, whether all the electrodes are correct or not. Once that is done, you do the microelectrode recording. There is another separate talk on this, so I won't dwell on this. So based on the number of trajectories where you get the best and the longest signal, we choose the track to stimulate. If all are equally good, then I always use the central trajectory. If 2 or 3 trajectories are good, then we check them individually and see which one gives the best results. If again the results are also same in all tested trajectories, then I increase the stimulus to look for side effects, and the trajectory with no or minimal side effects is chosen. Now coming to intra-clinical assessment. Here the role of neurologist is very important because surgeon is stimulating and the neurologist should keep on assessing the patient because we are partners in this. So this particular patient had a lot of rigidity. So now you see this is before starting the stimulation. Then we started at 1 volt, and if you see there is not much difference, there is a slight difference in the rigidity. But then you increase it to 2, and then suddenly it becomes very supple. So you know that you are in the right place. Suppose in one particular track doesn't show you good result, you know that the other track which showed you better result was the better option. So you keep on checking it at different levels. So you can map out the whole length of the length of the nucleus where you were getting good signal, and the electrode should be placed above and below that, so that this whole nucleus is in the center of the contact points of the electrode. Now you can see that it is very soft. Now we are looking for the eye signs in this patient. If you see, looking on the left, she is developing gaze paresis. Suppose if you are too medial and you may be stimulating internal capsule, as soon as we turned off, she was able to look laterally. So then you know that this is not the right track to choose. This particular patient had significant tremors. So now you can see that we are stimulating on the left side. You turn the stimulation on it. Sometimes it may take few seconds, and then the tremors just go. So here you can see that then at that time, once the tremor goes, you can check for other movements, rigidity and bradykinesia. And I'll just forward it a bit. So, and then you double check it. As soon as you turn it off, the tremors come back again. So that's why you can be sure that you are in the right position. Again, as I mentioned, to check for side effects, you normally we hardly ever need a 5 volt current, but here in this,
frequency is 130 and pulse width is 120.
We took it to 5 to look for any.
Sir, any side effect?
Sir,
any side effects, sir?
Gaze paresis, dyskinesias, dystonias, or any paresthesia.
No contraction.
Now the final step to put in the electrode, first you dilate the track that you have chosen, you put in a dilator so that sometimes the glue comes in the way, so you dilate it so that the track is made again, and then you choose the electrode. I personally prefer to choose the shorter electrode because it will go only up to the selected target point. Previously, when we were choosing the longer electrode, sometimes it would just pass the target point if you are not too careful. So this will stop at the target point. Now, once you have done it on both sides, you confirm it on the X-rays, and then you are ready to insert the battery. I prefer to do it on the same day in the same sitting, unless there is some either complication or you are too late. Then I do it the next day morning. If the procedure was being done under local anesthesia, then that is the time to give general anesthesia. We usually do it in laryngeal mask airway because no muscle relaxants are used, and the patient comes out pretty quick. So then you open the skin incision again, you tunnel the cable and take it to the chest. So here to start with, we are creating a pocket in the chest. I think the light is too bright so you can't see it. So we are creating a pocket in the chest. This pocket should not be too big, otherwise the battery will be loose there. Or if it is too small, then the implant will not have enough space, and particularly in a thin patient, the implant can extrude out also. So it has to be of the perfect size. So now this is the head. So from this is the scalp incision. From there you make the tunnel and take it down. So you have to make an intermediate cut here. So this is from the other side. You are seeing this is the head and this is the chest. So you take the tunneler, you make a small intermediate cut, and take the tunneler out through that. So now once the tunneler is out through that, then you again insert from here and come out from the chest. Sometimes the fascia at the base of occiput is too tough, so sometimes I insert a medicine bomb scissor and just cut it with that. Then it becomes really easy. And now you can see that this has come out through the chest wound. So in the next step, you remove the sharp tip from this tunneler and then connect this adapter here, which will take your connecting cables. Oh. So this has got two slots for holding the extension cables and which fit perfectly in this. I'll just forward it a bit. So you can see that you have connected it, you have fixed it into the slot. And once you have fixed it in, you just simply pull it out. And similarly, you can you do it from this hole to the scalp burr hole, and then the extension cable is close to the electrode. And then you connect the electrode and then the extension cable to the battery. So this is the extension cable which goes, you have to be careful which one is left, which one is right, because there are specific slots for that. And once you have connected it, you just insert the battery and close the wound. So this is the whole surgical procedure. Sometimes you can have complications. I'm not dwelling too much on the complications because Paresh has a very good talk on the complications in the next webinar. I've heard that talk and you should not miss it. The various complications can be intracerebral hemorrhage, seizures, intraventricular hemorrhage, electrode malposition, infections, lead fracture, or lead migration. This was one odd patient who had a venous infarct in the trajectory of the electrode, and it took him several months to recover from that. So another patient whose battery became loose because the patient kept on playing with the battery inside the chest, and the patient kept on rotating the battery inside the chest. That ultimately lead to coiling of the wires, and you can see the electrode, they were all coiled stringently against each other. So we ultimately had to explant that and put in new electrodes. This was published in Stereotactic and Functional Neurosurgery. So this is the X-ray of that patient. So the basic components of a successful DBS therapy are firstly the appropriate patient selection, and then accurate surgical DBS lead placement, absolute maintenance of hygiene during surgery, because this is a sort of semi-clean procedure. Patient is awake, a lot of people are there, people are continuously checking, you are removing the drape sometime to look at the hand or the leg. So you have to maintain the cleanliness in the OR so that the patient doesn't get any infection. And then the rest of the thing, optimal DBS programming, the medical management, and the management of the side effects, and then the patient's family and support. So with that, I'll conclude my talk, and I will give the screen to Dr. Ravi, and we'll take question answer after first two talks are over. Ravi, you can share your screen now.
Just a minute, I missed.
Nice talk, Sandeep. I think you covered each and every step, and it comes from your quite a large experience that you have, and it was quite personalized talk. So I think There are very, very small, subtle points that you highlighted in your talk, which were very important for a successful deep brain stimulation.
Is it visible now?
No, the screen is not
Not
visible,
yet.
Ravi.
Okay.
Dr. Ravi Verma is going to talk on surgical targeting and the art of surgical targeting. So let us learn from it. So we have tried to make all these talks in this webinar as personal as possible, because other things you can always pick up from literature and textbooks. But what you cannot pick up is the experience of the people who do these surgeries. And we have selected each one for their particular interest in that area. So let us hear how Ravi targets and puts the arrow through the center of the STN. Yeah.
So is this can see?
Yes, we can see well. Yeah.
So thank you very much for giving me this talk. And so I think most important thing in the DBS is to reach the right spot and have the right benefit. So that includes all what Dr. Sandeep has said, and subsequently what Dr. Rukmini is going to say, and finally, all the complications, everything. When we put in a perspective, I think that is what leads to a success of a deep brain stimulation. Now, to introduce functional neurosurgery involves precise surgical targeting and of certain anatomical structures. To localize these anatomical structures is one of the most important steps in functional neurosurgery. Now, the targeting techniques involve either an MR-based identification, anatomical-based, depending on atlases, electrophysiological database, and navigation, or a combination of all these. And I think combination of all these is an ideal situation where we can achieve the optimum target visualization. So what does it include? It includes a pre-operative imaging. The imaging should be appropriate, the right MRI, the right sequences in the MRI, and putting the MRI into a stereotactic realm so that you have pinpoint in a three-dimensional concept. You can pinpoint stereotactically where exactly you want to reach. Now, once you reach there, we need to prove ourselves that we are in the right spot and we have beneficial. That's why we have intraoperative electrophysiology. And then that will size the nucleus and where exactly in the nucleus we need to be. And subsequently, we need to image either intraoperatively or postoperatively to see whether you're in the right spot as we had planned. So what are the target areas? Most of them are in and around the basal ganglia. I'm talking about only movement disorders at this point. So I think I'll concentrate on STN, the WIM, and GPI, because these are the targets that are important. There are multiple other targets which I'm not going to go at this point. I think for 20 minutes and for beginners, I think this is the best STN, a lot of time on STN, and of course GPI and VIM. Let's start with subthalamic nucleus. As we all know, it's a small lens-shaped nucleus, which is there in the brain. It's part of the basal ganglia. It's located ventral to the thalamus, dorsal to the substantia nigra, medial and dorsal to the internal capsule, and lateral to the brachium conjunctivum and the red nucleus. So you can imagine how, very important spot that this nucleus occupies. It was first described by Julius Barnard in 1865, as early as 1865, and it approximately measures about 240 millimeters square in volume. Now, what is the functional subdivision? That's very important to know the functional subdivision of STN. That is because though it's a very little nucleus, 2 into 3 mm or 2 into 6 mm, but it's got everything. It's got a homunculus, and there are areas that in this which are important. And as we go further, I'll be letting you know why it is so important. So functionally, it's divided into the rostral 2/3 and the caudal 1/3. Now, the rostral 2/3 has a medial 1/3 and a lateral 2/3. Now, the lateral 2/3 has divided in the ventral and the dorsal part, and the motor circuit, which occupies a significant amount of the nucleus, is in the dorsolateral area of the nucleus. And the ventromedial will be the limbic and the associative territories, which again causes other issues if we start stimulating that area. So it's so important to get as close to or at the dorsolateral part of the nucleus. So why do we need to be precise in targeting, especially in the STN? One is the dorsolateral part is large and it is an important part. It's a motor part of the STN. To obtain the best possible effects in motor symptoms of Parkinson's, for example, that is the spot to be. And also it minimizes cognitive and behavioral influences. Again, when you increase the electricity, the amperes, you can affect the other areas. So as much as possible, we try to be in the dorsolateral area or the motor area of the STN. So what are the targeting techniques? Now, there are multiple targeting techniques, and I'll come to what we use, but talking about what all they are. One is the indirect targeting that's based either on anatomically, looking at the patient's MRI, or it can be atlas-based indirect. That means we're not directly looking at the nucleus, but we are calculating certain values of X, Y, and Z to pinpoint a particular area. Or it can be atlas-based. That means we adapt a particular atlas. I'll tell you how that is done. And then that atlas is put onto the brain, and then we imagine that that particular point is where we need to go. The most commonly used now and accepted is the direct targeting, which is MRI-based, and we use a T2-weighted MRI imaging. There are specifics in imaging that we will be talking later. And then we have the inversion recovery imaging, which gives us very good anatomical delineation of certain nuclei. And of course, third is red nucleus based because it's one of the most prominent nuclei in and around the subthalamic zone. So let's talk a little about history. In the past, it was all done using ventriculography. Schumann et al. Explained this in the 1999 from Paris, and I think Dr. Benabid is an exponent of this, who does all his work by using a ventriculography. A contrast is injected into the CSS space, and then the whole ventricular system is delineated. And here the ACPC landmarks are marked, and from there they calculate where the point should be, or where the nucleus will approximately be. Now, I have no idea who uses them still. I think Lenoble still uses some places, but I'm sure that it's more or less an obsolete technique because of the excellent imaging that we have got these days. Now, most of our anatomical targeting is based on commissures. That is the anterior commissure, which is a rounded nerve bundle which crosses anterior to the third ventricle. Then we have the posterior commissure, which is rounded band white fibers which crosses the dorsal part near the cerebral aqueduct. Now, that is called the ACPC line, and then the midpoint of the ACPC line is used to differentiate, to actually plan out from that point, either anterior, posterior, inferior, etc. So, for example, the STN is calculated 12 millimeters lateral to the mid-commissural point, 3 millimeters inferior, and 3 millimeters posterior. So that is an example. Now, a lot of people have spoken about various ways to look at STN. For example, Wheeler et al. In 2005 explained that it is the corner part which is present near the internal capsule and the substantia nigra, as shown in the picture there. Other anatomical based studies, Lee et al. Mentioned about the supramammillary commissure as a landmark, but this is very sensitive to ventricular enlargement, and so sometimes can be wrong when you plan it that way. The Todd et al. In 2009 had explained how to use the postmammillary commissure, the red nucleus, and the mammillary thalamic tract, which are all very clearly seen on MRI. And now this is being considered as a very reliable way of targeting the STN. Now, as I told you about the atlas-based, so what basically is done is there's a picture of the atlas. The colored picture you can see there is the atlas, and the non-colored picture is the normal brain of the patient, the said patient, and that is overlapped within each other and expanded to fix the nucleus. So we sometimes many brains vary in size. So according to race, according to region, there are different sizes. And so therefore, this is not a very accurate system, but then this was used by many people. And the Talarak and the Tornu Atlas by Ortego in 2008 registered non-linearly, which matching of the T1 method, which offers some good results, but again, there was some variation there. We could be in the STN, but not exactly where we required. The Scholten-Braun-Warn atlas, in fact, was made with 3 brains. And so it didn't give a good amount of variation. And we had to expand the atlas onto the MRI, and then, you have an approximate area, but STN is such a small nucleus, we cannot take approximations. We need to be very, very accurate. And that is why we have intraoperative MER, which helps us again lateralize and localize in the right spot. But the one atlas that is really good is the Montreal Neurological Institute Atlas by Goe et al. In 2007. Now here, both anatomical and functional data provides a very reliable region of STN, and this atlas can be used. But we commonly use the direct targeting technique. Person to person, it varies. Race to race, it varies. So direct targeting will always be targeted on the patient's brain itself, so there would be less chance of any variation. So the STN is identified as a hypointense almond-shaped structure. As you can see in the picture there, you can see the red nucleus, and lateral to the red nucleus, you can see the STN, which is, and if you look carefully, how do we reach this place according to the MRI? So we start with the ACPC slice, identify the largest mass of red nucleus. You go up and down in those cuts because it's a contiguous cuts of MRI. You don't have any in-between cuts, so that you get very accurate sizing of the red nucleus. Then we check the mammillothalamic tracts and the fornix, and also the base of the fourth ventricle on the axial sagittal cuts. Then we mark the anterior and the lateral border of the red nucleus. As you see in the picture, you can see the red nucleus there. So that's the superior part and lateral part. And you can see the green STN right there. And we reach the dorsolateral point, and the point of interest for us, which is about 2 millimeters anterior to the anterior border, 2 millimeters lateral to the lateral border. And this falls precisely in our area of interest, which is seen as hypointensity because of the magnetic susceptibility of STN. So once we reach that spot and we mark it here, again, you can see it on the MRI, and you can see the picture on a frame link, which is a software by Medtronics, where you can see very clearly where the STN is and how close to the red nucleus it is. Now, why is it important? Why is it important that we need to know? Because we need to know the boundaries of STN, so that when we stimulate, we find out exactly where we are, and we have an indication of whether we are true lateral, medial, etc. So we have the anterior and the lateral limits are by the internal capsule, the globus pallidus. Then we have rostromedially, we have the nucleus of Forel, the hypothalamic area. Posteriorly, we have the red nucleus. Medially also, we have the red nucleus. Ventrally, we have the cerebral peduncles and the substantia nigra, and dorsally, we have the zona incerta, the ventral thalamus, which are again good areas to place one electrode in among the 4 electrodes that you place, 4 contacts that you have in your electrode. Why is it important? Quickly, I'll go through this. I think this will be spoken to you, and when we talk about the physiological surgical nuances. The stimulation effect of, if it is too medially, you have diplopia, eye closure, deviation in eye, dizziness. So that's in the medial area where marked as M. If it is slightly medially, you have your MRI, the microelectrode recordings are very less and scanty. If it's very medial, then you have the red nucleus, which has very low density of discharges from the cells, and we know that we are not in the right spot. We need to get more lateral. If it is too lateral, we have dysarthria, muscle contractions, gaze, deviation, and other side effects. And so the ideal situation, as I told you, is the dorsolateral portion of the STN. Now, this is the final placement. This is by using a sure tune that once we finish, we check it with sure tune intraoperatively to see whether we have the right spot. You can see it all directions. Where exactly the nucleus is, the green is the STN, the red nucleus is red in color, and the substantia nigra, which is posteriorly, is yellow in color. So there are some neurologists who leave one electrode within the zona incerta region, that is in the superior part, and some neurologists like to put one electrode within the one contact within the substantia nigra, but that varies from neurologist to neurologist and what they believe, what philosophy they believe in. Now that's about STM. We'll go to globus pallidus interna. Globus pallidus again is a subcortical structure and is divided into the internus and the externus by an internal medullary lamella. Posteroventral globus thalamus interna has been used main target for dystonia and of course for Parkinson's, certain Parkinson's disease when we think GPI is a better target than STM, and there's a lot of psychological issues and things like that. The direct targeting is what we use here, and if you can see there in this picture, there is an inverted gray scale. You have a proton density scale where you can not really see it very clearly, but if you look at the inversion recovery, you can see where the arrows are, where precisely you can find the internal laminae. Now, this is very important to find this laminae because, again, according to this, we have to define where exactly we park. So the next point that we do is find out, identify the medial border. Once you identify the medial border, what you can do is you make a line there on the MRI, and then you have at the same plane, you have the ACPC line and you have the third ventricle, which is clearly seen there. And once you define this, you can divide the GPI into 4 segments. That is 1, 2, 3, 4 as seen in the picture. And here coming to that, we realize that the third quadrant shows improvement in limb, lower limb, center of the fourth shows improvement in the upper limb, junctions between the 3 and 4 is the cervicodorsal region. And reasonable volume of tissue can be chosen at this point. It's 1 millimeter anterior to this junction. So that is where, so that forms exactly in the MC, that is the mid-commissural point. And if you go lateral by about 13, 14 millimeters, you reach that part of the GPI. You can see the internal capsule also there. So the best point there is marked between 3 and 4, where you would achieve the best targeting. Now here, it's very clearly seen. You can see in the lower pictures, you can see the optic tract on the left side. You can see optic tract on the right side in the lower 2 pictures. And this is at the ACPC line. You can see the AC and PC quite very well. Now this is the point that we look for to get the best benefit in dystonia. And the target should be at least 2 millimeters lateral to the posterior lobe of the internal capsule and should be at least 2 to 3 millimeters lateral and anterior to the optic tract. So intraoperatively, if you can stimulate the optic tract and you have your neurophysiology in position in connection with the you will be able to see exactly, you can stimulate and you'll see photons as seen on the diagram. Now this is the position problems. You know, in GPI, if your preferred position for DBS lead is the posteroventral aspect, which I just showed you. You get reduction in Parkinsonian symptoms and in dystonic symptoms. If it's too medially placed, you have muscle contractions because of the internal capsule. If it is too laterally placed, you don't have the beneficial effects that you would expect from dystonia. Anteriorly placed, again, we have muscle contractions of the upper limb, facial pulling, dysarthria. If it's anterolateral, if it's posterior, paresthesia, numbness due to the medial lemniscus being stimulated. Now, this is a picture of the appropriate positions here seen to shear tune. You can see the electrode is placed exactly between the third and the fourth segment of the internal. So coming to thalamus, it's a big nucleus. It receives the VAO and the VOP, receives fibers from the cerebellum. Tremor cells are found in the greatest concentration in these areas for PD and ET, essential tremor and Parkinson's. The WIM is there, which is a major termination site for the medial lemniscus and the spinothalamic tract fibers. Tremor cells again are found here in PD. So when we actually examine the neurophysiological, you can find the tremor firings on your MAR, which shows you that you're in the right spot where the VEM is concerned. Now, how do we get to the VEM? These are the different reasons why we go to these particular targets. For example, if you want to target for rigidity, basically the VAO, and the VLA is the most important point where we need to find most of the electrodes. So since Thalamus is a very big nucleus, and we have the ability to increase the amperes and make the stimulation area much bigger. We can place it more or less in and around the areas that we're interested. For tremor, the VIM is the ideal spot, and for pain, again, it's VC and the VPN. How do we find out? According to Vio, the VM is located on the same plane as the ACPC. You can see that there, ACPC plane. 11 millimeters lateral either to the third ventricle or 13 to 15 millimeters lateral to the midline. And the midline would be the MCP, the ACPC line. From there, you go 13 to 15 millimeters lateral or from the third ventricle. Third ventricle wall is variable, so therefore, sometimes when you want to individualize, maybe the third ventricle wall is more precise. This is how we do it with the over-merging the Salton-Brown-Waugh atlas to approximately where the nuclei is, and we place the electrodes. The ideal location for a DBS, again, for tremor is considered 2 millimeters anterior to the VIM-VC border, and that will minimize the paresthesia, which is usually there and get minimized as we stimulate. And in the area where the kinesthetic neurons are detected, as we are examining the patient during the MER itself, we get the kinesthetic neurons firing, and when you touch the hands or the legs, you get these kinesthetic areas. So we know where these areas are, and where there are maximum concentration of tremor cells. If you look at in the firing, we can even notice tremor cells where the stimulation would do wonders. Now, there are many people who have given different ideas. So I think the best thing would be going anatomically and with the direct targeting, and also consider the indirect targeting as a help to get you to the right spot. Again, the stimulation effects, if it's too posterior, you'll have a lot of side effects that go on. Sensory stimulation that goes on doesn't come back. And if it's too anterior, there is, the effects on tremor will not be very good. And too lateral, you have muscle contractions because of the intercapsule. Too medial, you have possible speech and swallowing complications. And too superior, you have effect. So, but all these, again, saying it will be it's very large, because the nucleus is very large. It's unlikely that you're going to get all these things in your normal clinical practice, unlike in an STN where it's a very small nucleus and it's very difficult to go ahead. So I think the physiological part will be coming in the next talk. For a good DBS surgery, again, reiterating what Sandeep had said, is the right patient selection, accurate imaging, right target selection, and precision in electrode placement with the right programming. Thank you.
Thank you, Ravi, for a great talk. Anatomical considerations are always very difficult for a neurosurgeon to understand initially, but once you get into it, you do some cases, then you actually understand the concept. Are we ready for the questions? Are there any questions related to surgery right now?
So I'm just so there is a question as to how does one check the mammillothalamic tract on T2 weighted imaging?
Yeah, so in fact, can I go back to the presentation, or should I just talk? Because on the MRI,
there are two questions. If I can just put both of them together and maybe you can try and combine. The second question is, do you use double contrast in all cases? And maybe Sandeep can answer that question. Or is there any difficulty with trajectory planning with double contrast? And the second
we use double contrast in all the patients as a standard procedure.
Right. And the second question is, how do you check the mammillothalamic tract on T2 weighted imaging? And maybe Ravi can answer that question.
Yeah, so I'm just going to that particular picture to show the mammillothalamic tract. So first, the intermammalic tract right here. Just show you that. So here, this is the point here. Can you see this spot here?
You will have to zoom in.
Okay, sorry. I'll just present it.
No, here only if you magnify, because if you go to slideshow, no, it will not.
Okay,
You will not be able to magnify in the slideshow. So,
here I'll magnify. Okay.
huh.
So I think that. Um, sorry. Here. So just to show where.
While you're trying to
Yeah, here
project
it
it,
is.
if I can add,
You can see the first picture, and you can see just at the first picture on the frame link picture, you can see that the crossbar has been put there. That is the mammillothalamic tract.
Can you magnify it, Ravi? If you click on the picture and then expand it,
No, yeah, I think,
because we have gone into the screen slide share.
So we go back. Yeah.
Yeah, you escape on the slide share. Yeah.
So one of the ways to identify the mammillothalamic tract is to essentially, when you've done this T2 weighted protocol using the STN protocol, you identify the mammillary bodies, and sequentially on actual imaging, right?
This is the
mammillary bodies, you can essentially track it all the way. Correct. Those are the mammillary bodies.
Mammillary bodies here, and here you can see the tract right there. That is where the tract is.
And you can simply track it all the way to the anterior nucleus of the thalamus as well.
So we go forward and backward, we can go all the way to the thalamus.
Correct. Yeah. So hopefully that answers the question. We can initiate some discussion on the steps. Sandeep, if you want to initiate some discussion on the steps during surgery, or Paresh. Yeah. We have about good 10-15 minutes for discussion, Paresh.
Yeah. So the most important aspect about surgical planning is, first of all, you have to ensure that your MRIs are distortion free, because nowadays increasingly we are all going to become dependent on MRI based targeting. So that is very important that we understand the noise of the MRI, we have confidence, and preferably we should have the same MRI department and same place where we should be consistently doing the MRI. Second is going to be the error during fusion, because if we are not careful and if we are going to depend on someone else to do the fusion for us, then you are asking for trouble, because ultimately your data will be moved around and your stereotactic space will change if your fusion is not very accurate and perfect. And again, that goes on MRI acquisition of the MRI. One of the things that we have been following now over last almost 5, 7, 8 years, 5 years at least, is that we do an MRI under directly always 90% of the time under sedation or anesthesia. Even we don't accept sedation, we have an anesthetist, so we give anesthesia. So, and we do it one day prior, so that helps us to get a totally movement-free, clean MRI in the way that we want. In case we don't get the images that we like, we again repeat it. So we are heavily dependent on that. And I would also urge, where centers who are doing a little regular work, like 15 to 20 cases in a year, they should also do an introspective analysis of their data as to MRI based targeting and MER based targeting, and correlate what is the accuracy of their anatomical and physiological targeting. That will help in a situation when suddenly your MER machine stops working intraoperatively. It will give you the confidence whether you will be able to conclude your surgery just only on anatomical targeting, or you would not be comfortable. So these are a couple of points which are for advanced centers, but for people who are beginning, concentrate on getting a good MRI.
Can I add something?
Yeah.
So some of the other tips when you're actually planning the surgery, in addition to what has been mentioned so far, regarding the imaging protocol as such, there is obviously there is dependence on the MRI scan for identifying the nucleus. And at least as Paresh said and as Sandeep said as well, that I do an MRI scan the previous evening, and I just rely, and it's obviously a distortion free MRI scan, and the next morning it is a CT scan. So one needs to be aware that a lot of centers use, a lot of technicians, unfortunately, don't necessarily pay attention to what sort of a CT is being conducted. If you do a spiral CT, you are likely to make an error. So one needs to be very aware that it is not a spiral CT and it's an actual CT. Because if you do a spiral CT, you will essentially make an error in calculation, because CT is the one which is being used to try and make sure that your coordinates and AP, means X, Y, and Z coordinates are obtained. And if you don't have that sort of a differentiation made out right in the CT scan machine itself, then you could land up with, getting inadequate MER recordings, and then you would be wondering as to why are the recordings not proper. So you may be, if you have accidentally or rather not paid attention to the fact that it is not an actual CT and a spiral CT, you could be in trouble. So one point of note is that. One other point which I would like to mention is what Sandeep was mentioning, was the use of the drill. The, you know, it is very, very important to try and make sure that the burr hole cap which is being used is a very, very good fit. Because unfortunately, if it is not a good fit, and there are multiple ways of drilling a hole. So many people would just use a proper 14 burr. I simply use a simple drill. So Sandeep showed he uses a drill. So, but the burr hole cap has to be very snugly fit. If it is not a snugly fit, then eventually at the end of a few months, you may find that there can be some elements of migration. And there are multiple fixation techniques for it as well. But if the burr hole cap is loose, then eventually there can be some movement in the future, electrode movement in the future.
Same observation I've made. If I make the burr hole coaxial, that is right perpendicular to the bone, it fits better than if you do it along the trajectory. Sometimes doing along the trajectory.
You are right.
It
fits better because then it is perfectly circular. Right?
Yeah.
Because you are perpendicular to the bone. When you are making the burr hole in the direction of the lead, it is not a perfect circular, but still it fits pretty well. I've never faced a problem.
You're on mute, Paresh.
Yeah. So what I have found a way out of this is that I use a handheld burr and perforator. And what I do is that I use the central trajectory of the MER as my guiding. And as we all know, this is going to be a 14 millimeter burr. So if we use the central trajectory, I can pinpoint which is a 1 millimeter point on the skull. And then if you are using a handheld burr and perforator, which has got a conical perforator, the tip of that conical perforator will pierce in the center. And then you make a burr hole which is parallel with a handle. So we have our customized burr and perforator of the exact size, so that we never worry about the burr hole cap being going loose. So that helps us to get the right fit on that, and also the trajectory and also the perpendicular burr hole. All three problems are solved because, and it's a little tedious, old-fashioned, but it has worked. So in fact, we even do not depend on the hospital burr and perforator. We have our own, which we get it sharpened after every 5 surgeries, because that is something very simple and you can get it done repeatedly. So
one we get with Codman, the 14 millimeters.
That's a perfect fit.
Perfect.
Yeah, that is also a good fit. Yeah. That I know that but somehow that this problem about this perpendicular trajectory was not getting so easily solved in my hands. So we went to back to the old things. But as I think Milind said, many things can be done in many ways. It is something that one is comfortable with continuously. And same thing is for us. We also go for actually spiral CT scan, but being aware about what are the advantages and disadvantages of that. So it is something that, as I said, we should be careful about how we do our things and consistently do the things so that you can pinpoint any faults or mistakes that occur on the way. I think, Sandeep, we can move on to the next talks because we just reached.
I just had one question if you want to take it.
Yeah.
No. The question was, I think this, which side do you do first and how do you account for brain shift between the two sides? And have you assessed the difference in the brain shift between the two sides?
Sandeep, you want to answer?
I normally do the worst side first. Like if the left side he has more symptoms, I do the right side first.
I personally do the right side first and then come to the left side because I bring the right electrode to the left side. And for the brain shift, we do not open the dura. So that's why we have been able to manage the avoiding brain shift.
I do the dominant side first, whichever side it is, the dominant side first. And I think it varies from surgeon to surgeon.
Yeah.
Which one you do
Same
first.
here. I do the dominant side first. So generally, as Ravi and Sandeep mentioned, I try and figure out which is the worst side and try and correct that side first. And I do a single incision, so I don't have to. I don't have two incisions. Like from what Paresh said, I gathered that he must be doing two vertical incisions, whereas
And
I take.
No, I take a round incision, a C shape, because initially I used to take vertical, but then it used to come over the burrow. So I didn't want to bring it. So two C
So
shape.
I do a horizontal incision.
Yeah.
I do one single horizontal incision. So then it doesn't matter which side do you do first.
I agree. Yeah.
And even if you you use the glue, as Sandeep said clearly, that a lot of brain shift and pneumocephalus can be avoided.
Yes, that's another way of reducing it. Yeah.
So we come to the next talk. Is speaker ready? Right.
Hello.
Hello, Rukmani.
Hello, Rukmani. Hi.
Thanks, sir. Good evening, sir. So shall I start, sir?
Yeah. Sandeep, you are announcing?
Yeah. So Dr. Rukmini will be speaking about the physiological targeting of the
At the onset, I would like to thank Dr. Paresh for giving me this opportunity to present here. And just
give me a minute. Dr. Rukmani is a neurologist and she has been associated with the movement disorder and deep brain stimulation surgery as a passion for, I think, one of the largest number of years in our country. And they have been also having a large experience of DBS in Hyderabad. Yes, Rukmani. Yeah, carry on.
thank you, sir. So my talk is on physiological mapping in DBS. So what do we mean by physiological mapping? It's an integral component of the functional neurosurgery. It started like that because at that time anatomical targeting was not really good. But even despite the progress of the new imaging techniques, which are much more refined and which can actually pinpoint it very categorically, we still continue to use physiological mapping because we are more confident after the use of physiological mapping. The common methods that we use are, we use both intraoperative microelectrode recording as well as macrostimulation techniques. So why do we need a physiological mapping? So anatomical localization is based on direct and indirect methods, as we have already heard. The error can happen in fusion techniques if the patient has got a lot of tremor, and it's not patient cooperation is definitely required for the imaging process. And the quality of images are really important. Intraoperative CSF leaks can happen, brain shifts can happen. So physiological mapping can help in confirming the location of the lead. And finally, I think at the end of the day, all of us want that the lead should be in perfect position. Because unless you are in the perfect position, you are not going to the patient is not going to improve. So the technique of the microelectrode recording, which is the first step, varies from institute to institute. Some institutes use a single microelectrode recording. Some use a sequential microelectrode recording in 2 or 3 targets. Then some people use 3 or 5 simultaneous MER records. A frame-mounted drive system is used, as has been demonstrated by Dr. Sandeep Asia, and then a cannula is inserted, and the microelectrodes with macroelectrode is then located into each cannula till the tip of the cannula. The MER actually have either platinum, iridium, or tungsten tips with an impedance set in the range of 300 to 600 kilo ohms. The neural activity is displayed both visually on a computer screen as well as it's transmitted to an audible signal. So both the sound as well as the visual impression is important. And we in the operation theater, we usually look at the raw signal and we categorize and identify the neuronal activity. There are a lot of sophisticated techniques which are available which can actually analyze the raw signal and can look at things like local field potentials. But that would mean that it has to be done offline. possibly in the future there could be a automated machine which can pick up these signals and give us an idea about where exactly the situation is, I mean the lead location is. So what are the side effects of microelectrode recording? I mean, it's so simple. If you just have to have a microelectrode recording and then you can do it in all patients, well, there is an additional time required. But the main concern that happens with all of us is that additional passes through the brain with the microelectrode or the macroelectrode causes an increase in hemorrhage risk. There's been changes in the design of the microelectrodes to avoid or to reduce the hemorrhage risk. But then, and then there have been papers which suggest and which doesn't suggest. There is a recent review which suggests that there is definitely an increase in the hemorrhage risk with the number of microelectrode passes. So that is a complication that we would add on when we are using a microelectrode. And the third thing that is important is a cost factor. Now, if we look at a US based review, because they separate out the ST&DV, we don't actually think about the microelectrode cost so much, but if you see a US based review, it seems if the MER is added to them in their operation theatre, the cost actually increases to almost 106, I mean it's almost more than double the time, so it's 267% of the cost of the DBS. So it is an important aspect to look into, especially in terms of if you have insurance based funding, so so we have to make sure that the intraoperative microelectrode recording is useful. So this is, I mean, I'll just give a brief overview of what we do in STN microelectrode recording, and this is how the microelectrode passes through and we get the signals, and the signals that we see on the microelectrodes are actually spikes as well as on the background noise. Now the spikes are the single neuronal stimulating electrodes, and the background noise is what picks up as the multiple synapses which are firing. Now what happens in Parkinson's disease patient is that you have an increase in the background noise, and this is what is typically seen in the STN, and you have an increased amount of firing of the neurons which are irregularly firing. And then once you pass from the STN to the SNR, you get a very smooth and a clear, a very uniform firing rate with a reduction in the background noise. And this is useful to pick up the STN when we are in the operation theatre. So the microelectrodes, this is a setup in NIMS, Nizam Center of Medical Sciences, where we've been doing the surgery since 2000. And this is, we still use a 5 microelectrode recording simultaneously. And this is the MER machine where the microelectrodes are actually started, I mean, they are, we record it at levels from -10 to +10 at each 1 mm interval. And this is where, if you can hear you can see that there's a blue line which is there. These are the 5 channels which are going on. So the blue line is where the firing is going on with the STN. So this is at each level. So, and when we have an SNR recording, which is an old recording, so you can see that there's a uniform recording with a which is a uniform recording with which we can be seen. So this is a typical picture about, we can actually on the MER machine we can record 10 seconds or 3 seconds of the MER that the microelectrode recordings that pass through at each level, and then you can reanalyze it once you finish the analysis from -10 to +10. So this is where you can see a typical picture from one channel, and you can see that there is reduced recording on the top, and then you have an increased firing in these 3 segments, and then again you have a reduced firing. So there is an increase in the background noise, which means that the base becomes broad, and the spikes are firing at very irregular rates. Now, why is it important to look at these MER in patients with either Parkinson's disease, dystonia, or in tremor? Is that one, it can identify the STN because it's got a characteristic signal. You can also do certain maneuvers, like in case of STN, you can actually do a movement-related increase in the, movement-related increase in the firing, which suggests that you are in the sensory motor STN. This is very important because STN is actually divided into multiple areas. So the ideal option of putting a lead is to put it in the sensory motor or the dorsolateral part of the STN, as Dr. Ravi Verma has already said. And for that, the best option to look at is the amount of MER recording that you get, and also whether there is a response of the MER with movement of the lids. So that picks up the sensory motor area of the STN, and you are more sure that you are going to have a good response. You can also look at it, I mean, if you want, this is a different mechanism of looking at it. You can actually do a fast Fourier transformation at the same time, and you can look at the signal in the the power of the signal which is generated, and this is how we pick up whether the patient has got it's there in the STN or not. We had just done a very small study where we had looked at 46 patients who had undergone DBS in over 3 years period, and then at that time we had looked at the mean number of channels in which the STN MBR was detected. The mean number was around 3.5 in the right side and the left side was 3.6, and the absence of the microelectrode recording in the final channel selected was in 6. So out of the 6 patients, 1 patient had no recording and the lead was just placed in the central after stimulation. So if you look at the concordance, we looked at the concordance with the superior Morse signal analyzed, noted, and also the maximum width of the recording. The concordance of the with the highest recording was seen in around 58%, that's only 60%, and the maximum width of the STN was seen in 48%, and concordance with either the highest recording or the maximum width was noted in 64%. Now this is something which we need to know, that even though we look at microelectrode recording as a standard where we can actually identify the sensory motor cortex, we rely more on the stimulation effects rather than more on the microelectrode. Microelectrode recording gives us an idea of where to stimulate maximally, and based on that we look at we stimulate the patient, and once we look at the stimulation parameters, we look at the response as well as the side effects, and then we decide on where to put the lead. So the other thing that you can do, as I said, was to look at the local field potential, and you can actually, this is another study which is ongoing, and this has been done. I mean, you're looking at beta wave power and the gamma waves, and you look at the beta waves on LFP. This right now is at a stage where this has to be analyzed offline. You can look at the spectral density of the beta power, and then once you look at the beta power at the maximal spectral density, you can actually see that there is, on stimulation, there's a reduction in the beta power, and I think this in the future with an automated machine would give us a very good clue on whether the lead is in the sensory motor part of the STN. But similar to the STN, we also have it in GPI and in the thalamus. I will not be going into it in detail, but it is, again, when you reach the GPI, you actually get something what is similar to STN, the recording. So it's important to see that you're not placing your electrode in the GPE, because if you put it in the GPE, you are not going to get a good response after the surgery. So the idea is that you pick up these microelectrodes and you can actually target the particular area that you want to. Similarly, in thalamus, you can look at the tremor cells, and if you have a tremor bus cells and you have a response on the table, then you are you are really happy that, and to know that the success will be there. This was one patient who had a stroke with after a cardiac pacemaker was placed because of a cardiac arrhythmia, and she had a midbrain lesion, and she was severely having a tremor in both the sides. Again, this is in the old parlance would be called as a rubral tremor. Now that the terminology has changed, and this was the recording that we did when she was getting operated. See, there were two advantages of doing a microelectrode recording in her. One was that we picked up the tremor bursting cell. It was a 2 Hz frequency stimulation that was seen there. She had a cardiac pacemaker, so we were not able to do the MRI. So most of our planning was done on the CT. So this was the recording. So you can see that in the top 4 segments, that is the up to 4 mm, you can see a very typically 2 Hz frequency. You can see the frequency is similar to that of the tremor. So this is something which you can pick up in BIM. If you look at a tremor bursting cell and if you have additional electrophysiology, or you can do it on visual, if you have a visual guide and see that the tremor frequency and the bursting frequency of the neurons are similar, you are sure that you are in the position. And this was during the surgery. The tremor in the hand has come down markedly. So intraoperative, so that comes to the next part of the have an intraoperative test stimulation, and you find a good response, then you are really happy and you know that you are in the position, and you can come out with the lead there. So this is Dr. Rupam initially. So you can see that the tremor is going, and as soon as the stimulator is switched on, there is no tremor in the right hand. And once that stimulator is switched off, you again get the tremor. This is not something that we see all the time. Out of all the three, out of all the three parameters that you check for, tremor, akinesia, and rigidity, the rigidity is the most sensitive and the thing is the tremor can be intermittent, and sometimes the tremor can come on and off without the effect of the stimulation itself. And bradykinesia depends upon the patient's cooperation, and so the rigidity is easiest to check. So once you look at the rigidity and you see that there is an improvement in the tone, that is the best way of knowing that the patient has got improvement in the motor symptoms. So when you do an intraoperative macro stimulation, this is done by the same cannula which contains the microelectrode. This is a patient who had was undergoing STN-DBS. We do a lot of STN-DBSs. So this is a patient who had dyskinesias on table, and once you are having a dyskinesia on table, we call it the sweet spot. We know that the lead is in the STN. Again, if you have on-table dyskinesias, that's a good sign that the patient is going to have a good improvement post-operatively. The side effect profile which can happen with the stimulation is the second part of the stimulation. So you increase the current, and you can, based upon the location of the lead, if you're medial or if you're lateral or if you're anterior or posterior or superior or inferior, you by the stimulation of the surrounding structures, you can have various side effects, and this can depend upon whether you're doing STN or the GPI or WIM. It gives you a clear-cut localization as in where you are particularly there. So this can be used very nicely to map. So this is just a picture of what are the stimulation-induced side effects which can happen with an STN stimulation. So I'll because it's a short talk, I will not well into it into much detail, but it is given in most of the there are a lot of books and a lot of papers which have been published upon the MER as well as the MER parameters as well as the stimulation-induced side effect parameters. Just a few more thought process on whether really a physiological targeting is required or not. This was a paper which was done in 2016, which was published on 50 patients with STN-DBS, and they looked at the spatial distance between the anatomical and the functional targets. For this anatomical and functional targets, they used both the imaging modalities as an anatomical target, and the functional target was both the intraoperative MER as well as the intraoperative macro stimulation. And they found that there was a difference of around 2 mm plus or minus 1 mm, so which is like ranging from 3 mm to 1 mm, which is a significant distance which is seen between the anatomical and functional targets. So that's another, and this is the thought that I would like you to consider, that MER is essential because you would want to have a functional targeting, not only an anatomical targeting. But on the other side of the story is that people are now more and more tending towards asleep DBS, where they want to have the patient under general anesthesia, especially for people who cannot tolerate the DBS surgery in the awake state, especially if you have dystonia or if you have very severe tremor. So there are you have intraoperative MRI to look at the patients with under general anesthesia. There was a recent meta-analysis which was conducted in 2019, where they used 14 cohort studies with 1,523 patients, and they looked at the post-op improvement in the patients who had undergone GA, asleep DBS or local anesthesia. Now the point with asleep DBS is sometimes you can actually still look at intraoperative stimulation even under GA, especially you can look at the stimulation-induced side effects. Whereas MER recording doesn't, MER recording can sometimes come in, but most of the times it is not feasible under GA. So what they found out was that there was no difference in the UPDRS-3 score improvement or the post-operative levodopa requirement or the operation time. Even other adverse events like post-operative speech disturbances and intracranial hemorrhages was similar in both the groups. Pneumocephalus was definitely lower in the GA group, I think because of the controlled environment that was being undergone. So to conclude, electrophysiological targeting definitely helps in confirming the functional location, may predict a better response. The jury is still out on the requirement of MER, but intraoperative stimulation is definitely a good sign, and it gives you a visual clue, and you are really happy once you look at the intraoperative stimulation. The other thing that I would just add is that having a physiological mapping also means that you have a neurologist in the OT. So 2 eyes are better than 1 eye for any surgery, I suppose. So that probably is one more role of physiological targeting. Thank you.
Thank you, Dr. Rukmini, for a great talk. This is a controversial topic. A lot of people are for MER and a lot of people are against MER. And then there's always a debate between general anesthesia surgery versus awake surgery. So I think we will discuss that after the second talk. So I invite now Dr. Peter Wadia, who is a movement disorder specialist at Jaslok Hospital. And he's also on the board of Movement Disorder Society of India and Neuromodulation Society of India. Dr. Wadia.
Hi, good evening, everybody. Is my screen visible? And am I audible?
Yeah, both.
Okay, thank you very much. So firstly, thank you very much for Rukmini for setting the stage, and also thank my previous speakers for already showing the anatomy of the STN and the side effects. So that will make my life a little easier. So I think in the previous session and this session, you've gone through patient selection. You've selected the right target, decided where you're going to put the electrode. With the intraoperative methodologies that you saw, you have placed the electrode, confirmed its placement, internalization and IPG placement is done. You've done physiological targeting. Now it's time for programming. So today, this programming is going to be broken up into 2 sessions. Today is going to be standard DBS programming, and we're later on going to cover advanced programming options and the future in the next talk, next session, next week. So what is the timing? When should we be doing post-operative programming? So should it be done in hospital, or should we wait until the patient has completely had a lesion effect? So many of the Western countries where the patient really doesn't pay for DBS, very happily will tell the patient, okay, we'll see you after 6 weeks or 8 weeks, or whenever your Parkinson's symptoms or dystonia symptoms are back to baseline. The practical world is, if the patient has paid so much money out of pocket, like in India, I don't think they're going to wait for 6 to 8 weeks. So we do initiate a programming post-operative while in hospital, provided you can. Otherwise, you set it as per what you think is the right targeting, setting a very low stimulation, and just so that you feel that you've started something and they start and get used to the stimulation. But often it requires a fresh, full reprogramming couple of months down the line when the lesion effect comes. So although you may start the programming pre-operative, post-operatively, you really almost many times have to do a real full reprogramming session at a subsequent date. You have to program in the off medication state, especially for Parkinson's disease, because really, I mean, if the Parkinson's symptoms are not there, you really don't know what you're programming anyway. And as we already talked about the lesion effect, so when you put the electrodes in the STN or the GPI or the thalamus, depending on what target you're dealing with and what disease, you are likely to have a significant improvement for a period of time ranging from sometimes up to 6 weeks, sometimes even longer reported, sometimes even a couple of years have been reported, where there is an improvement, which later on wears off as the edema around the electrode subsides, and later on you will need to program it. And you also need to assess the stimulation side effects while you are programming. So the first thing you have to begin with is checking the impedance. The impedance is what's going to tell you the situation of the circuitry which you have implanted. So this is how the impedance would look like on a standard Envision programmer from the Medtronic system. The current programmers allow us very certain ranges. The amplitude you can do up to 3 volts. The pulse width and the rate is fixed on the Envision, unfortunately. So basically, you'll check the impedance in single mono contact, that is contact with the case, and you also do it in bipolar configuration. If the impedance is too low, you have to avoid those contacts. If the impedance is too high, you need to look for an open circuit or broken leads. So in the immediate post-operative programming, you will call the patient in the off medication state, preferably overnight off medication is ideal. If the patient says, oh no, there's no way I will come in the off medication state, which actually post-operatively is not very common, because post-operatively there is some lesion effect. So they are probably a little more willing to come in the off medication state. So if not, then at least 5 to 6 hours off medication is probably recommended, but I would say overnight is ideal. The electrical setting, when you're first starting stimulation, you're looking at taking each contact in a monopolar fashion. Now, this is a 4 electrode Medtronic lead, but the Boston may be 8 electrodes, or you might have directional leads. Whatever it is, you're going to check the electrodes in monopolar configuration. You have to keep some variables fixed. So usually we keep the rate 130 Hertz, that's a mid frequency range, and the pulse width should be 60. Really, you don't need higher pulse widths. Do not really help you in Parkinson's disease. It spreads the current too much, and the STN is already small. So really spreading the current is not going to help you as far as Parkinson's is concerned. So 130, 60. So you fix the frequency, fix the pulse width, and then you go step by step, increasing the voltage, 0.5, 1 volt, 1.5 gradually, or you can even go even stepwise by 0.1, 0.2, depending on how much time you want to spend. But if you get, and you have to keep monitoring for side effects as well as efficacy. So at each contact, you're going to go step by step, looking for the benefit after about 30 to 60 seconds of constant stimulation. And you're also going to assess the side effects while you're increasing the amplitude, and you're going to evaluate for the threshold of the side effects. Now, this is the interface of the Boston system, the 8 electrode Versailles system, where you have 8 electrodes in a monopolar in a configuration of ring electrodes, not the directional ones. We'll discuss the directional ones in the advanced programming session next week. And here you'll have different programs which you can select. Then you can select whether you want the left electrode, left STN, right STN, and you can add 2 extra areas which you may want to stimulate. If you wanted to have something like an interleaving pattern, you can adjust your pulse width, your frequency here, and you can adjust the amplitude here. So each system has a slightly different interface, and very soon the Envision interface is going to go away, and you're going to get the new Percept PC. So interfaces are going to change, but the basics of programming remain the same, depending on whichever system you're operating. As Dr. Rukmini mentioned earlier in her talk, rigidity is probably the most important feature and the most predictable feature in terms of improvement, because it doesn't change with fatigue of the patient, which will happen in case of bradykinesia. And you can even measure small changes in rigidity very easily when you're increasing stimulation, and the changes in rigidity are very rapid. Tremor is useful when it is present. Gait is something that you will have to assess at the end, but you cannot keep on going on making the patient get up and walk at every 0.5 millivolt change, because he's going to get fatigued. Bradykinesia will help when there is no rigidity, but really you have to be very careful not to tire it out, because once the patient is fatigued, the patient is not going to cooperate. Stimulation-induced dyskinesias, when present, yes, that's the eureka sign. That's to tell you that, yes, we are in the right position. But occasionally, dyskinesias can become very, very bothersome. So this is the way you'll sort of map it out at contact 0, contact -1, at contact 1 minus, 2 minus, and 3 minus. In monopolar fashion, as you gradually increasing the world, you'll say there's no change in the rigidity, 20% change, 30% change. And while you got a better rigidity improvement, maybe at contact 2, at a lower voltage. So at 2 volts, you got about 40% improvement. At 3 volts, you got 60% improvement. So you can make out that contact 2 and contact 3 are the good contacts and a reasonably good threshold. So you can say that contact 2 is probably the one that's going to be a useful contact. So when you chart it out, it becomes very obvious. Sometimes you're not able to separate whether contact 2 or contact 3 is better. Then what you have to do is to have a blinded operator where you change, one person changes the setting, and the blinded operator then assess blindly as to whether he thinks bradykinesia, rigidity, gait are better in one contact over the other. Or the patient is the blinded rater and decides which one is better, depending on how sharp or not sharp the patient or the relatives may be. Then what about the side effects? If you're too medial, you're likely to get vegetative side effects. If you're too medial, you can get diplopia. Vegetative side effects will habituate and the patient will get used to them over a period of time. And if you go slowly on your stimulation, very gradually increasing the stimulation, you should not have a problem. If you're too lateral or too caudal, you're likely to get motor stimulation, contractions of the muscles, dysarthria. If you're too posterior lateral, you're likely to get paresthesia. So depending on the side effect you're likely to get. Now, the target, as mentioned, is the STN. If you're too lateral, this is what you're going to get. If you're too medial, this is what you're going to get. And this is your substantia nigra. This is the pyramidal tracts. So that's how your side effects will depend on where your electrodes are placed. So again, habituation occurs for flushing, perspiration, paresthesias, the vegetative symptoms of the media and paresthesias. Ocular deviation can habitate. Some of the bilateral eyelid opening or closing may habituate. Dyskinesias may habituate, but muscle contractions are not likely to habitate. Ataxia is not likely to habitate, to habituate. So there the side effect threshold is unlikely to change. So these are the steps to a basic programming visit. First, the assessment should be done in the off medication state. Check the surgical site whether there is healing appropriately. Check the baseline UPDRS so that you have an idea whether the patient is as bad as he was preoperatively or not so bad. Then check the impedance. Then set the case as the anode and the contact as the cathode, and check the pulse and keep the pulse width and frequency fixed at 6130. Then record benefits as I showed you in that chart, gradually increasing the voltage. Note the threshold for the adverse events and the voltage when they are noticed. Check for each contact in monopolar settings and check the benefits and threshold. Choose the best contact in monopolar setting and maybe start with a low voltage. What voltage you set can be variable as per what your experience and setting is. Usually we tend to start with a 0.5, or if the patient is very bad, maybe a 0.8 voltage, because you're worried that when you actually give the medicines, he can have severe dyskinesias and may actually feel that, oh my God, the DBS was a failure. And assess the subject with the medication on again and see how it is, because you can always reduce the stimulation in case the dyskinesias are very disturbing. And gradually over a period of time, you start increasing the amount of stimulation. Once the stimulation is switched on, you also need to start simultaneously lowering the Parkinson medications. The medications which can be directly stopped are the anticholinergics, the COMT, and the amantadine. While when it's the levodopa and dopamine agonists, we lower the dose, but we never tend to stop it completely, because when you stop it completely, you're risking the risk of postoperative depression. And depression is very common in the post-op period. So unless 6 months are over, I would not stop any of the dopamine agonist or levodopa completely. I might bring it down to about 75% less, but I would tend not to stop it completely. So what happens if the patient's symptoms are not well controlled? What are you going to do next? You're going to check the lead position. You're going to check the impedance again. And then you're going to check the contacts. You have different contact options. You can use double monopolar stimulation where you stimulate two adjacent contacts. You can do bipolar if you're having side effects so that you can focus the stimulation. You can do interleaving and you can do fractionation of currents. I'm going to be discussing all the contact changes in the next talk next week. You can modify the pulse width and you can modify the frequency. So when do you change the frequency? So your frequency range will be low frequencies at 60 hertz, high frequency going up to 230 hertz. And this is how you'll adjust the frequency on the Envision. So when do you choose a low frequency stimulation? Low frequency stimulations typically help if there's freezing of gait. Again, it can be variable. Some of the freezing of gaits can actually even improve with high frequency. You can actually help the speech. If there's a lot of dysarthria, stimulation induced low frequency stimulation can help. Akinesia may worsen on low frequency, and tremors definitely will worsen when the frequency is lowered. It is useful for certain active symptoms, especially freezing of gait. The higher frequencies really helpful for tremor, for postural instability, and for fascination. If you're having disturbing fascination, increasing the stimulation can be a huge asset. Downside, dysarthria may worsen and your threshold for stimulation will worsen. So your amplitude of stimulation will have to come down when you increase the frequency. So this is a gentleman this is the pre-op video. Sorry for the slight change in orientation. So he has a lot of freezing of gait. When we ask him to walk, he has great difficulty in walking. He's great difficulty initiating a step. And he uses tricks, but he's still got significant freezing of gait. You can see the humongous difficulty initiating a gait. And now you can see that we're holding his hand, still difficulty initiating the gait. He's even seen that doorway and freezing even more. And then once he takes off, you'll see that he's able to walk much better. And this is the same gentleman in the on medication phase, indicating that the freezing is levodopa responsive. And what we had to do for him after stimulation, when we did DBS for him, we had to use a low frequency stimulation. You can see we're using 60 hertz stimulation. And the freezing did improve, and this is off medication state. He has had subsequently some amount of freezing. We have stayed on 60 hertz now. It's subsequently more, it's I think more than 5 years since the DBS, but he still continues to do well in the on state. Still has some freezing when it's in the slightly off medication state. So this is just to highlight the point that for freezing of gait, you do need to use a low frequency stimulation. The traditional pulse width in the Medtronic simulations has ranged from 60 to 450 hertz. Increasing the pulse width really helps in dystonia, sometimes in tremor when you want to spread the current. In STN, because it's a small structure, increasing the pulse width typically causes more side effects, more pyramidal side effects. So I would rarely ever do more than 60 hertz, 60 microseconds in terms of pulse width. However, there's, I think, very lot of increasing data showing lowering the pulse width may actually focus the current and may actually have improvement in the threshold. So this is a very good paper showing you when you lower the pulse width below 60, you can actually increase the amount of threshold. And therapeutic window was 2.16 volts at 60 microseconds here. And that therapeutic threshold increases 182% at 30 microseconds. So this is the percentage change of the therapeutic threshold, 182% at 30. So there's a substantial increase in the threshold when you go on. And this is rigidity control versus contraction. And the same thing changes here. Current in amplitude and pulse duration in inverse. So higher pulse widths, useful in dystonia. In Parkinson's, rarely do we ever go about 90, as I mentioned. In tremors, occasionally in the VIM, you can increase the pulse width, but the current may spread and you might get side effects. I think the bigger focus is on lowering the pulse width. When you again want to increase the therapeutic window, again, akinesia may increase on lower pulse width. So not every time you get away with a lower pulse width, but in certain stimulation situations where a certain side effect is affecting you, a lower pulse width may help. This is an example of a 58-year-old lady who had Parkinson's since 2000. We operated her in 2015. She was 58 when we operated her. Her offs were very bad. She was unable to move. Ons were pretty good. Her UPDRS off medication, 36, on 10. So all in all, a good criteria for DBS. She was on a fair amount of medication, but was having dyskinesias in the on stage, and that's why she had to undergo DBS. This is her medication in 2013. You can see significant bradykinesia. same lady state. You can see the mild dyskinesias. And see how slow she is in the off state versus her on state. So clearly, I mean, you can make out that a good levodopa response, a good candidate for DBS. So she underwent DBS. Post-operatively, we battled a lot of dyskinesia and dystonia on the left leg. And this is just within a year of post-operative, it wasn't too bad. But it got worse over time, and we had to frequently inject botulinum toxin injections to her. And this is 2008. To deal with the situation, we had given her an interleaved setting, but you can see significant dystonia, dyskinesia of the left leg. So she literally had to take support most of the time, and you can see very unstable because of the left leg dystonia. So subsequently, we had a battery change, and she chose to have a 25-year Versailles system, and we were able to. We had the opportunity of lowering. And with the lower pulse width, we've not had foot dystonia. The requirement of Botox has completely stopped. She feels she's steadier on her feet, and she's able to walk even without support, which she wasn't able to do earlier. So this is just to highlight that when you lower the pulse width, you are able to reduce some of the side effects which were happening from the stimulation, and we got some improvement in her case. So I'll move on to programming in dystonia. Programming in dystonia differs slightly from that in Parkinson's disease, wherein you get a pallidotomy-like effect which can last for several weeks, again, just like in if you have a subthalamic effect. But the same principles you'll assess at a fixed frequency, fixed pulse width. Among the side effects, we are looking for phosphenes and visual flashes seen especially in the lowest contacts because of stimulation of the optic tract. You can also have contractions if you're too medial with the face, hand, and contraction. Sorry, too lateral. And the time course, unfortunately, is different from Parkinson's. So if you stimulate a person with dystonia, you do not expect an immediate improvement in the dystonia. Many times they take up to 2 days, 3 days before they see an effect on the dystonia. So unlike in Parkinson's, where you can finish the program very rapidly, in dystonia, you have to give the patient a day or two on each contact before you can say that this contact was better than the other. So you might take much longer in terms of choosing the right contact in case of dystonia. Again, GPI is a much bigger structure. So you need to use higher pulse width, and sometimes you need to give double monopolar stimulation or stimulate multiple contacts to spread the current in the GPI. So the phasic movements of dystonia and the pain has a rapid improvement, while the tonic postures are a slower improvement in case of dystonia. So what might improve first is the phasic neck movements in a cervical dystonia, but the actual neck position might take longer to improve over a period of time. And interestingly, in dystonia, you can continue to improve for years and years and years. And that's really rewarding, because over a period of time, the patient can have almost a 90 to 100% improvement with DBS. Usually the ventral contacts show a good response. And once you've chosen the best contact, you initiate on a standard frequency and voltage. But if the benefit is suboptimal, you have to use a higher pulse width. You may, Both frequencies have been tried, high frequency, low frequencies, and there have been papers that low frequency may help dystonia, and you might actually save battery life. You may use monopolar stimulation, or you might use double monopolar stimulation, and sometimes all of the above. So programming in dystonia, you might have to use a lot of tricks to spread the current. But the other tricks like having to lower the pulse width and all is not very commonly required in terms of treatment of dystonia as compared to what you need with treatment in Parkinson's disease. So this is just a case example to show. This is a lady who actually had an unusual phenomenon of a DYT1 dystonia. She was DYT1 generation. She had a lot of truncal and neck involvement in her dystonia, not so much lower limb involvement. And this is what she is post-op. We've unfortunately not been able to see her in follow-up because of visa restrictions that are there. She lives in Pakistan. And she's actually done very well with the initial programming that we've done. And she's got a rechargeable system, so there's no worry about battery change at the moment. So now we just touch upon programming in tremor before I end the talk. So in programming with tremor, just like in subthalamic nuclear stimulation, wait for the thalamotomy-like effect to subside. As in Parkinson's disease, again, and dystonia, fixed frequency, fixed pulse width to start with. The side effects to watch for would be paresthesias and ataxia especially. And tremor response is instantaneous. You can actually finish the programming in one session. So at every step of stimulation, you just ask them to keep drawing a spiral and find the best spiral across the different contacts. Then within that same contact, you can change the frequencies and see which frequency is best and best tolerated. Often you might need to use a higher frequency to get a better tremor control, but it can be pretty rewarding for programming of tremor. So I'll conclude the programming here. Go stepwise, use a monopolar setting initially. Only if it doesn't work, we have to use different contact configurations. Frequency modification helps in low frequency helps freezing, high for tremor or fascination, or severe postural instability. Pulse width reduction can improve the therapeutic window, especially in Parkinson's disease. In dystonia, we may have to choose a higher pulse width to spread the current. And for tremor, you might have to use a higher frequency to give you a better tremor response. And what I've kept for the next session is the further advances in programming, interleaving, fractionation of current, a little bit on directional leads, which I think are pretty exciting. Adaptive DBS, a little bit, which Rukmini already highlighted in, and then the other ways of guided programming. So thank you very much for your patient hearing.
Thank you, Dr. Wadia. It was a great talk. And as a neurosurgeon, when we are directly not involved in too much of programming, I really learned a lot from you today, and I would be really waiting for your next talk. And Milind, are there any questions?
Yeah, so there are two questions. One, if I could, one is directed at the surgeons and the other one is directed at programming. The one which is directed at the surgeons is to how to deal when the burr hole is too big and the ring is loose. And the second question is on the what is the deciding factor or what is the upper limit of the current when you're looking at stimulation induced side effects.
So I'll take the first question. If the burr hole accidentally becomes loose, in that case, we still put the ring, connect the electrode through that, and then at the end of surgery, we place a mini plate over it and then tighten it. I had to do that once and it did pretty well.
So the way I do it is so that burr hole ring by itself has two holes. on the either side, particularly the Medtronic one.
So directly.
Has 2 holes. So I try and make sure if it does become loose, then essentially put in a 6 mm screw or an 8 mm screw through those 2 holes so that the ring gets fixed there independently. And I use a mini plate in addition across the lead every time. That is a routine in any case.
I don't do that routinely.
Yeah. I also do that routinely. Yeah.
You do that?
Second
No, I
question,
don't do that
Petrus.
Only if the cap is a little loose, then you put a mini plate over the cap, but otherwise I don't put a separate one on the lead.
Same here.
There are many places actually in Europe, many of the places they even put bone, the cement, and then they cement the whole place. And some places they put a mini plate over the electrode and fix the electrode more than the.
Luckily,
yeah.
So luckily that mini plate by itself or the burhole cap by itself has a hole, 2 pre-decided holes, so through which you can put in a screw. So that is one way. And many years ago I have also needed to essentially create a new hole because the burhole got a bit more loose. But that's essentially a rescue situation. So there's one more question for you, Petrus. There's another question from the audience. It is essentially, what is the upper limit of the stimulation that you would use, or what is the deciding factor? Maybe I think that question was initially directed at Rukmini. So Rukmini, if you could answer that question as to what is the upper limit of the of the current that you would use to figure out the stimulation induced side effects and for otherwise as well.
I mean, intraoperatively, actually, something like 3 volt, and you're getting a side effect, a facial deviation, or if it's this is very common if you're a little lateral, and this we have seen. So we have actually chosen the medial contact. If we get a stimulation-induced corticospinal tract spread, especially in Parkinson's disease or even in GPI, if it comes even at 1 volt or 2 volts or 3 volts, we would think about going a little medial to that tract. So for me, it's that being said, it is also important to realize that impedances changes very markedly during the operative procedure. It is not the same as sometimes you may actually get a very the response may be much more than what you would see after in the post-op period. But for us, normally we look at side effects that we think that the side effects will come around somewhere around 5, not less than that.
Yeah, I have another point there, just a question or a comment. When you, for example, when you have the lead place, you have an amplitude at about 3 or 4, you get some side effect, but you get very good beneficial effect at 3. And how many times, because when you leave it in the dorsolateral region, you're very much ectatic where the nucleus is concerned. And if you go beyond 3 and 4 and you get a side effect, ideally you're in the right spot, because it's dorsolateral. And even if you go at 5, 6, 7 and you don't get a side effect, then I would think again twice whether we need to go to that spot or not, because that may not be an ideal spot. So I think if, as you said, if 3 amperes is 3 to 4 amperes, you get a very good beneficial effect, but then you get some side effects. What would you do?
Sir, we would still probably go with the same contact. And especially if you have dyskinesias, if you get a good, if you have a response and you're having dyskinesia, especially if you're in STN for PD patients, we would still take it. If it is, you're getting a good response at 1, the point would be that we would like to get a threshold.
Yeah.
And that respond at 1 or 2, and then you get a side effect at 3, we still would choose that depending upon.
The therapeutic gap is very important. I think 1 to 3 if you get, or 0.5 to 3 if you get, or just placing it to 3 you get. Yes. You get a good therapeutic window. I think that is also very important to look into.
I had 2 comments. One was about Rukmani's talk about awake versus asleep DBS. Apart from, on a lighter note, the asleep DBS may be done without a neurologist, which I would not like it, or you may not like it, either way. The meta-analysis, I'm talking for the benefit of the people who are listening, is something that in such cases we have to take it with a pinch of salt, because meta-analysis talks about several studies across several regions, and this surgery of deep brain stimulation is a very individual surgery. You are seeing five neurosurgeons who have been doing it across India, and all of them have personal preferences and personal choices about how they do it, the finer points of surgery. Now, the results of all of them will be different, and the comfort level of all of them will be different with different techniques. And that is why, if you remember, in the initial part only, I said that you should have your own internal check about your accuracy of anatomical and physiological targeting. That is first observation. So unless you are confident that your anatomical targeting matches your physiological targeting, you should not attempt to do a sleep DBS. That is one important recommendation that I would make. And second important aspect about asleep versus awake DBS is basically when you are doing an asleep DBS, you do not have any handle about where you are. So once you have put the electrode, that is a final position, there is very little that you can check. Again, there is a learning curve, and I will tell you why I'm saying this is that we take the extrapolation of spinal cord stimulation. We do not do spinal cord stimulation in our country as much, but world over, there is a huge amount of spinal cord stimulations being done. For example, in US, there are 130,000 spinal cord implants done a year versus 30,000 DBS. Similarly, in UK, there are centers which do around 20 implants in a month or 30 implants in a month. Now, we know that the way we do spinal cord stimulation for pain and spasticity is that we probably do a trial stimulation and followed by a permanent implant. UK, USA, Australia have come to a conclusion by evidence-based medicine. Now, again, I'm talking about evidence-based medicine, level 1 evidence, that you do not require a trial stimulation. So if we extrapolate that and we start doing the same thing here, we would have a big failure. Why? Because they are talking about people who are getting experience of doing these implants, 30 implants, 50 implants in a week or a month in huge volumes. Their experience cannot be compared with our experience. So all this literature has to be interpreted in the correct context. Asleep DBS, awake DBS, what we are talking about, these are being talked about at centers who are doing more than 20, 30 implants in a year. Their experience of 200, 300 DBS implant helps them to target the nucleus with 100% accuracy. So that was my thought process for the asleep and awake DBS. And one comment for Petrus. Dystonia programming is very, very difficult. And I think, Petrus, you covered the programming session very well. And usually you do this very well. So it's very explanatory and very useful for all the people who are starting in this field. Dystonia programming is very tricky. It's something that, again, you should not endeavor to do in your initial first 5 years of your career. And if you are doing it, then use an experienced partner, because the amount of combinations of pulse width that you have to do, and along with the frequency, as Petrus mentioned, we have had dystonia patients who have responded to 210 hertz, and we have had dystonia patients of cervical dystonia responding to 80 hertz. Now, how do I come to that conclusion? And Petrus told you that it takes 2 days or 3 days or 1 day, 48 hours to come to a conclusion whether your programming parameters will work or not. So your patient will get tired, you would get tired. It is going to be very difficult sometimes. So take some caution, and especially when you start dystonia, and take a good partner along with you who has got more experience to help you in programming.
Yeah, another point over there about this dystonia, the effect of dystonia, the effect of stimulation on dystonia happens much later. It takes about 3 to 6 months to get the best benefit.
Yeah,
so
the reason is
like
that
Parkinson's.
The reason is that you can't find the 3 to 6 months is because you can't find the sweet spot. It takes a period over time to do that. Petrus, you wanted to say something.
I'll answer both the comments. One is, I think what Ravi Gopal Verma said is correct. As I showed you in the graph for dystonia, so the tonic dystonia response is very slow. So in fact, we've had a patient which I was with Dr. Morrow. He did a DYT1 where every year that little dystonia symptoms which are remaining resolved on their own at the same setting.
Exactly.
without changing any contact, without changing any amplitude. But year by year, she just got better, better, better without doing anything different. So it is just the fact that the tonic movement takes much longer to improve. The phasic movements improve faster. So you're quite right that the response may take 6 months to a year, and you just have to just dig your heels in and sit tight. So that is one aspect. Second aspect is, I think the challenges that were there in dystonia programming when I started out with the earlier Medtronic systems, where we had one set of program which we could do at a time, versus now most subsystems that give you 4 programs to run at one time, are hugely different. I mean, now you can actually say that, okay, I'm giving you a plan for the whole week. Monday you try this, Wednesday you try this, Friday you try this, and Sunday you try this. See which one works. Take videos of yourself and come back a week later. So I mean, you don't have to call them every second day like we used to have to do earlier. I mean, the stress on the system is much less because you can give them 4 groups. Say try each group, and even in dystonia, I think that the method to do is first just go by and select which is the best contact. Then within the contact, once you establish that this is the best contact, then you play with the pulse width, then you play with the frequency. You don't touch the pulse width and frequency initially, because if you do that, then as Dr. Doshi says, you're going to have so many options that you're going to be lost. So it is first establishing your good contact or / contacts. Many times you do double monopolar stimulation. You'll take 2 contacts, especially in a Boston Versailles electrode where you got 8 contacts. You'll probably stimulate 2 out of those 8. You're not going to just stimulate 1. Yeah, Rukmini has to add something.
Nothing. Actually, that's true.
I'd like to add something.
We do it every second week. I mean, we change the contacts from the. I mean, we look at the contacts every second week. Like not. I mean, we tell them to go for 2 weeks, come back, again go for I mean, give a pair of contacts and then go again and come back. That's true. The other thing is that we put them on high currents, contrary to what we put in the STN, where we start with 0.5 volts. Actually, typical dystonia, I mean, this is what we do. We start with 3 volts or more than that, and then tell them, okay, you stay on 3 volts and 60 hertz and 130, I mean, 60 microvolts and 130 hertz. Stay for 2 weeks, come back, and then again we check it with that. So that's what we are doing.
You're not going to go 0.5 volts and go upwards like the way you're doing it.
Correct.
Right.
Most important thing is patience.
I can make a couple of comments. Yeah. Go on, Ravi, after you.
No, I was just telling you the most important thing in dystonia, I think, is patience and time. And as Petrus said correctly, if you get one point, just stick to it for months together, and you're going to get the benefit in due course.
Yeah. So if I can make a couple of comments here. One was on the programming in dystonia. I would actually concur with what Petrus said. One needs to try and differentiate between the phasic movements and the tonic movements. So I have this, I have quite a significant experience on dystonia surgery. And the most important part is the differentiation between the phasic movements and the phasic movements and the tonic movements. Phasic movements, actually, we've seen improve within hours. And that chart which was put up by Petrus is literally true. Means on the day of stimulation as well, the phasic movements have stopped. It is within a few hours. And the same is true for DIT1, if you're talking in terms of DYT1, and appropriately so without any change in the stim settings. And it is true that you would essentially have a slow and progressive involvement with improvement with time without any change in the stimulation settings whatsoever. So very true that dystonia is, this is the chart which Petrus had showed. And effectively, if you note the red line is effectively on the day. We are talking about on the day or within a few hours, you would see some change in the phasic movements to happen. Whereas if you're talking about tonic posturing, it takes quite some time, and which is really the fact. Particularly in primary dystonia, it takes a little while. And if you saw one of the patients which Petrus had shown, that young girl, she had significant improvement, and I'm sure as time goes by, her improvement will continue. The second comment was about the topic of asleep DBS and how does one, the comment that Paresh had made. The concept of changing over or giving up on the physiological targeting as a method to try and reach the endpoint or the end result that you want is something which evolves over a period of time. But one needs to understand that even intraoperatively there are multiple steps which you can take, and one of the steps which many of us actually do, but I would like to highlight the use of an intraoperative MRI scan, which Rukmini mentioned briefly in one of her slides. Intraoperative MRI scan, though not necessarily recommended by the companies, they have been having tremendous reluctance to do that, but I've been practicing use of intraoperative MRI between stage 1 and stage 2 of the surgery. That means before I put the IPG, on the same day, I use an MRI scan, confirm the lead placement and the electrode placement. And that is possible now, given that you can essentially have a good quality MRI scan, identify the leads, and essentially once you've identified and happy with the location, this essentially, tries and helps out you to, whether you want to then do it in a sleep DBS or whether you want to argue about doing this as an awake DBS. But if you do this regularly, then you know that this is what you set out for, this was what you had chosen as the target, and if you can stay at that target, then that is going to be a determinant factor for your long-term result. So these are a couple of comments on these two topics.
Yeah, the comment on again on sleep DBS and intraoperative confirmation. So we do the same thing. We use OAM in Aster, and then we confirm it even before putting the leads in. So the OAM is put with both the leads in position, and then we confirm it, merge it, and see the positioning of the electrodes. But I think, how many times have we always stuck to central line? I mean, central one is what anatomically we would have placed using the MRI, intraoperative MRI, and without, in a sleep DBS, I think that is where we would place it. How many times have we placed on the central? The many times we do the anterior or the posterior or the lateral is
Actually,
something
that is to answer that question, Ravi. One of the best things is to essentially have an intraoperative MRI scan, because if you have an intraoperative MRI scan, you essentially are able to see the electrode position in relationship to your STN.
Yeah, same thing we can do with SureTune. With this new software, we can see in the STN, which I showed you in the last picture.
Yeah, that's the software based.
What I'm saying is between anterior, for example, between anterior and central, sometimes there's a change. You get a much better benefit with anterior than central. And if you were doing sleep, inverted commas, you would have put it in the central. But the benefit that you get in anterior was better than the central. And that is where I have this doubt of whether sleep would be adequate enough. Once we have directional movement, I think that would be okay.
No, sure enough, nobody is debating about the fact of use of intraoperative MRI scan. I have continued to use intraoperative MRI scan for the past 20 years and will continue to do the same.
Sure. Same. I think it has the same effect, same benefit as what we do with the CT. But we do have, in fact, in Bangalore, we have an intraop MRI, which is attached to the OT. So we just take it in, take the patient in. I'm doing a study comparing all these three, whether it's worth, we can just do a CT with SureTune or just do an MRI. So I think once we get an idea, but what is intriguing is the fact that we are never in the central as much. Maybe 90%, 70%, 80% we are maybe in the central. But the 20% makes a difference.
I think, Ravi, what you are saying is correct, and that is the observation for most of us. We are around 60 to 65%. Probably Rukmani would have the same as target central, and what you are. That is why I said, and I am repeating again for the third time, that you require your internal quality check. This is something that you cannot extrapolate from the literature. This is your check. Unless you have done 100, 200 DBS, you should not try to venture into this. That is my suggestion. People can decide what they want. I think with that, we should end the session. We had a very good interactive discussion.
One question from the audience. This is aimed at the neurologist. Can stimulation worsen the behavior of an individual or a cognitive behavior of an individual or day to day? So does any of you, whether Rukmini or Petrus, any of you could take this question?
Go ahead, Rukmini.
stimulation-induced
Sorry, I
behavioral
think
side
both of
effects.
us are in that whole thing about who's going to go first. Yeah, both stimulation can cause worsening of the behavior. Impulse control disorders have been, I mean, one of the indications of doing DBS is to reduce the dopamine agonists and to reduce the impulse control disorders in patients. But if you are in the associative part or the limbic part of the STN, if you're a little medial, you're actually there. You can have either apathy, which can cause a lot of depression, or you can be if you're. I mean, you can have worsening of psychosis. You can have worsening of impulse control disorders. Especially in the first 2 years after DVS, there are some instances where you may be worsening the behavioral abnormalities. So that can happen. And the point is that you are also going through the frontal, region. So, yeah.
Can I add to that? Yeah, so we've actually had frank mania when you've stimulated one contact and that switch occurs within like 24 to 48 hours. Typically, it's a ventral contact where you're stimulating the limbic STN. I mean, I've had a situation where the patient actually wanted to take a knife and stab the spouse. That kind of mania, violence, I mean, to the extent that you literally have to bring the patient back in an emergency setup. So, I mean, I remember the presence of mind of of Elena Mora that time. She said, first switch off the stimulator. The rest of it we deal with later.
We had reported this in 2002. One was depression following subthalamic nuclear stimulation, and second is hypersexuality. Both are again known, and hypersexuality falls again in the impulse control disorders that Rukmani mentioned. We reported both these things way early in 2002 and 2006. And now they are known symptoms or side effects to be watched out for in case these are induced by stimulation. So we have several of them. Some of them we will cover it in the next session where we talk about the complication. And I think we can start to decide to close the session. I have my co-moderators here back. Sandeep is there. And Sandeep, I will share the screen for thanking Intas. And if you have to say any comments or anything.
Oh, no, I'm sorry. My Wi-Fi had disappeared for last 3-4 minutes. So I missed what happened in last 3-4 minutes.
No, we are just closing. So we had just some
Okay.
discussion about behavioral side effects. That's all.
Okay, that's fine. So I think you can just, it was a great session and it was very good talks. And I would look to Vadia's next talk.
Yeah.
And
So,
I think you can meanwhile show this slide and then we can.
sure. And once again, we thank Intas for helping us to conduct this webinar and look forward to their continued support to the society. The next webinar is going to be the third in the series on movement disorders, neuromodulation, and this would be on next Thursday. See you all then.
Thank you.
Bye, and thank you all the faculty and the delegates.
Thank you.
Okay.
Thank
Bye.
you, everybody. Bye-bye. Bye.
Thank
Bye-bye.
you. Bye.
Bye, Patrick. Bye, Rukmini. Bye.
Rohit, we can stop the live.